Hello, everyone, and welcome to another episode of Dr. Gilbert Hosts. Today, we're going to be talking about 3 advanced therapies for Parkinson's disease with 3 experts in this field. Now, you probably have heard, we talk a lot about 2 of them, deep brain stimulation or DBS and focused ultrasound. And the third we're going to talk about today is known as stereotactic radiotherapy or SRT. So we're going to be discussing these 3 procedures, how they work, what symptoms they do and do not treat, in what circumstances you should consider these procedures for yourself, what are the reasons to choose one over the other, etc. And we're going to hear from 3 experts, as I said, who do these procedures. And then after they give their presentations, they'll be taking your questions live. So get those questions ready. So to start us off, I'm going to introduce our 3 experts. We're going to start with Dr. Brian Dalm. He's going to be discussing deep brain stimulation. He's a neurosurgeon specializing in neuromodulation. He received his medical training at Loyola University and then completed his fellowship at the University of Iowa. Prior to joining The Ohio State University, he was a director of the Pain and Functional Program at Houston Methodist. Dr. Dalm's research focuses on using neuroimaging techniques to predict which patients may benefit from neuromodulation early in their treatment. The next up, we will be hearing from Dr. Andres Lozano, who will be discussing focused ultrasound. He is the past chairman of the Division of Neurosurgery at the University of Toronto, where he held the Dan Family Chair in Neurosurgery, and he currently holds the Alan and Susan Hudson Cornerstone Chair in Neurosurgery at Toronto Western Hospital, University Health Network, University of Toronto. He obtained his MD degree from the University of Ottawa, his PhD in neurobiology and neurosurgical training from McGill University, and postdoctoral training in movement disorders at Queen's Square in London, UK, and in cell and molecular biology in Toronto. Dr. Lozano has an active laboratory dedicated to the study of neurodegeneration and functional neurosurgery, and he is a world expert on this topic, pioneering new applications for deep brain stimulation and focused ultrasound. And finally, we'll hear from Dr. Evan Thomas. He'll be discussing stereotactic radiotherapy. He's the founder and chief medical officer of the Renaissance Institute of Precision Oncology and Radiosurgery, and he's the adjunct professor at the University of Miami. He uses advanced stereotactic radiosurgery to treat movement disorders. He completed his medical and engineering education at the University of Alabama, where he earned both an MD and a PhD in biomedical engineering, completed an internship in general surgery, and a residency in radiation oncology at the University of Alabama in Birmingham, where he also pursued advanced fellowship training in radiosurgery. He specializes in treating complex brain and nervous system conditions with stereotactic radiotherapy. Thank you, everyone, for joining us and sharing your expertise. Really excited to hear your presentations, really excited to join in a Q&A with you. And we'll start with Dr. Dalm, who will kick us off with his presentation. Dr. Dalm.
Thank you. Thanks for everybody for joining. Like Dr. Gilbert mentioned, I'll talk about deep brain stimulation therapy for Parkinson's disease. No relevant disclosures for this talk. So how do we get with DBS therapy, deep brain stimulation, or DBS like we call it? It was sort of by accident to some degree. We used to do, this was before my time, we would do radiofrequency ablations for things like tremor in the thalamus. And before they would actually burn the tissue with these radiofrequency probes, they would stimulate to verify they were in the correct spot. And if they did higher frequency stimulations, they noticed that they would get a lesion-like effect. So then they took that observation, did studies with it, and then eventually the discipline of deep brain stimulation therapy ultimately came from it. So by the numbers, we've had this therapy for about 30 years now. Sorry, I think I skipped there. Sorry. So what do we have as far as our targets? 1997, we have VIM, which is a target within the thalamus to control mostly tremor. And then in 2002, we had FDA approval for both STN and GPI targeting, 2 structures I'll show you some pictures of later for the motor symptoms of Parkinsonism. So how good have we been as far as being able to provide this therapy for patients going forward. If you look at just the US in general, there's about 1.1 million people in the US at any given time with Parkinson's. And it's estimated about maybe 1 to 2% of those actually end up getting it. Not all 1.1 million patients are eligible to receive the therapy, but once you whittle it down to patients that could be eligible for the therapy, we really haven't done a great job, both within the neurology community and within our neurosurgical community, about really making sure that patients are aware of this and being able to offer it and implant it for patients that can benefit from the effects. So we call it deep brain stimulation therapy. The picture on the right-hand side kind of shows the blue, the thalamus, more that yellow, the subthalamic nucleus, and then that kind of pink or almost reddish structures, the GPI. They're deep within the brain. That's why we call it deep brain stimulation therapy. They're somewhat close in relationship to each other. And our job as the surgeons is to identify the targets, make sure we're targeting the correct thing, and then accurately getting to those targets. So every time we do one of these therapies, we want to hit that bullseye every time. So how do we go about doing that? Largely, we've used what are called stereotactic frames. So the left-hand side of the screen kind of shows the traditional frames. The right-hand side are some of the more kind of frameless technology that has come about over time. But essentially what these do is these allow us to align a trajectory from a pre-planned target that we've already picked based on what we're trying to go after, whether it's VIM, STN, GPI, and then to place the lead accurately in that spot. Well, as time has gone on, things have gotten better as well. We've are in the field of robotics within surgery now. Neurosurgery is no stranger to robotic therapy, and deep brain stimulation therapy lends itself very well to this type of technology. There are two companies that make robotic devices that we use for lead implantation. All these robots do is they align the trajectories of where we want these leads to go. They're much more precise than us manually inputting the coordinates into the frame-based systems. So if we were to take that position, move it away, bring it back, move it away, bring it back, it would be at the same exact spot.
Have we lost Dr. Dalm? And at this point, we may. Dr. Dalm, are you there? It may make sense to move on to the next presentation until we get Dr. Dalm back.
I mean, I'm happy to narrate his slides. I can interpret the slides because I do this surgery as well. So that's another option. We can either.
That sounds like a great idea. Thank you, Dr. Lozano.
Right. So it is possible to confirm the location of the electrode intraoperatively using X-rays to make sure that you indeed reach the target that you intended. And the slide on the left shows the intraoperative fluoroscopy image confirming the position of the DBS electrode once it's inserted to target. Next slide. So this is a measure of the accuracy, and these are all within about a millimeter of each other. So it's a very these techniques are very accurate, whether you use MR, a robot, CT guided, or frame based. They're all approximately within a meter, 1 millimeter of target using these various techniques. Next slide. So there have been several advances in DBS therapy, including better imaging, better target accuracy. The surgery can be done either awake or asleep. The results are the same, whether the surgery is done with the patients awake or asleep. For the comfort of the patient, some of them prefer to be asleep during surgery. There's been the advent of directional leads that are segmented so that you can throw the current in one direction or the other to try to improve efficacy or to reduce adverse effects with the stimulation. It used to be that the stimulation was on 24/7, but now we use adaptive stimulation where the stimulation is only used when needed. So we detect an abnormal signal called a beta oscillation in the brain with the electrodes, and we turn on the stimulation automatically when this abnormal signal is detected. And so this is now adaptive stimulation where it is adapted to the patient's need, and this is proving to be quite useful in some patients and reduces the amount of stimulation, the total stimulation, because it's only used when needed. The batteries are getting smaller and smaller, and they're now rechargeable. So indeed, they're getting, the battery life can be up to 25 years with these batteries. And also there are significant upgrades both in the software and in the battery technology. So the message is that we're moving from a surgical therapy, which has much more flexibility and with increased ability to target and to program and to enhance the benefits to the patient. Next slide. So the complications of DBS are common to any surgery where an electrode is penetrating the brain. There's a surgical risk placing the electrodes. There could be, for example, if you hit a blood vessel, you could cause bleeding. There's a hardware risk because you have permanently implanted electrodes and a battery. And of course, it could also be risk related to or adverse effects related to the stimulation, where the stimulation causes a side effect. And the advantage of DBS is that, of course, you can turn down the stimulation or turn it off completely. And this is why it has an advantage over lesion-based surgery, because it's adjustable, whereas lesion-based surgery is not. The complication rates from brain hemorrhage is less than 1%. Infection is in the order of 2 to 3%. Hardware-related problems are long-term, as long as you have the hardware, and it can be 5 to 15%. Any complication is 8 to 15%, and mortality is exceedingly rare, maybe 1 in 10,000 with these procedures. Next slide. So that brings us to the next speaker, who's Dr. Lozano, and that's me. So I will just continue. So we've heard about DBS from Dr. Dalm. I tried to do as good a job as I could to cover his territory, but now we're going to move to something different, which is transcranial high-intensity focused ultrasound for tremor and Parkinson's disease. And here, what we're going to do is we're going to try to treat tremor and other disorders with ultrasound, which is this at the bottom here on left. But indeed, you should know that there are 4 alternative therapies, 4 alternative surgical type therapies, including DBS we've just discussed. There's also radiofrequency lesioning, where you can place an electrode and burn the target cells with radiofrequency heating. There's also gamma knife and LINAC, which you'll hear more about from Dr. Evans. And then what I'll concentrate on is MR-guided focused ultrasound. So these are the 4 alternatives, and I've used all 4 of these techniques in my patients. Focused ultrasound involves focusing 1,000 beams of sound through the skull to one focal point in the brain. And it's very much like using a magnifying glass and focusing all the sun rays onto one spot and burning a hole in a piece of paper. It looks like this with the helmet in place with the 1,000 beams. We're able to measure the temperature and aim very precisely 1 or 2 millimeters within the brain and measure the temperature as we're applying the sound. And in so doing, we're able to create a thermal lesion deep in the brain. And this lesion can be 1 millimeter, 2 millimeters, 6 millimeters, 8 millimeters, as large as we want, based on how much energy we deliver. This is what these lesions look like. Here's a thalamotomy immediately after. This is at 1 week, at 1 month, and at 3 months. It's almost invisible to see. The next slide shows you that not only are we doing thalamotomies for tremor, but we are now moving beyond tremor to treat the other symptoms of Parkinson's disease, such as bradykinesia, rigidity, gait disturbances, and dyskinesias, by treating the globus pallidus, doing pallidotomies with ultrasound, doing subthalamotomies with ultrasound. And one of the most recent innovations is using the pallidothalamic tract. So doing PTT tractotomy, pallidothalamic tract tractotomy, to treat tremor, rigidity, akinesia, gait disturbance, and dyskinesias in Parkinson's disease. So this is the procedure that is gaining the most traction now, is the pallidothalamic tractotomy to treat Parkinson's disease. This is an example of a patient with tremor who has undergoing high frequency focused ultrasound. And this is if you turn the slide on the right as well, if you can, this is the patient coming in, and this is done as an outpatient. The surgery now takes about an hour and a half. The results are immediate. So you see that this patient could not drink water before, and now after the procedure, he's able to drink water. So we are doing multiple procedures per day. In fact, our record is 6 patients in one day. It's taking us about an hour and a half per patient to do these procedures. The patients stay about 1 hour after the procedure, and then they go home. And so it's done as an outpatient. These, for tremor, the results are immediate. You see here, this is before, and this is 1 year, 2 years, 5 years. So you see that it's immediate and sustained after 5 years. And we can also do this on both sides of the brain. So in this particular example, if you look at patient number 2, this on the arrow was the first side and the star was the second side. So this can be done safely on both sides of the brain, but we always leave an interval of 6 to 9 months between treating one side and the other to let the brain recover. But it is now possible to treat both sides of the brain with high intensity focused ultrasound. The results of this work have been published in multiple journals. In the last month, there was a publication on bilateral pallidothalamic tractotomy, and this is really one of the more exciting aspects of focused ultrasound. This is now FDA approved, and it is treating not only the tremor, but also the bradykinesia, the slowness, the rigidity, the dyskinesias, and the gait disturbances in Parkinson's disease. So this, I think, you're going to be hearing much more about in the future is PTT tractotomy. Just to give you an idea of the number of cases that are being done, these are the number of ultrasound cases and the number of DBS cases done in the United States for tremor. You'll see that the number of DBS cases for tremor in the green line are steady, about 1,500 cases per year. On the other hand, the number of focused ultrasound cases started out low, and then by the year 2021 reached the number of DBS cases. And now, as of 2021, there are more focused ultrasound cases done than DBS cases done for tremor. So this is a general trend where focused ultrasound is reached and is now surpassing DBS in many cases. In terms of the volume of cases being done with focused ultrasound is now getting to be greater than the number of DBS cases, certainly for tremor and possibly in the future for all other movement disorder indications. Just to give you some examples of the differences across these various things, we'll just concentrate on focused ultrasound. So the results are about the same in terms of tremor control, about 60% tremor control across all modalities, including DBS, ultrasound, gamma knife radiosurgery, and radiofrequency. Similar quality of life improvements across all of these, similar side effects across all these conditions. So there does not seem to be a great difference in terms of benefits or adverse effects with these procedures. And just to give you some highlights in terms of with focused ultrasound, you do need to shave the hair. You do need to wear a frame. You get an immediate result. It is not adjustable. That is not reversible. It is possible to do bilateral treatments now. When I made this slide, it was not, but now bilateral treatments are approved. It does not require an implanted device. So these are some of the important attributes of focused ultrasound. Just to finish off with, this is patients that undergo pallidothalamic tractotomy, patient with Parkinson's disease with bilateral tremor. This is after a PTT lesion. So you see 1 month later, her tremor has disappeared. This is a patient with Parkinson's disease who's on a pump and who has dyskinesias. And this is after a unilateral left-sided pallidothalamic tractotomy. You see the dyskinesias are gone. So you see that the pallidothalamic tract is showing promise, not only for tremor, but also for the other aspects of Parkinson's disease. So I think you'll be hearing more about PTT lesions in the future. And with that, I will introduce Dr. Evans, who will talk about radiosurgery.
Good afternoon and good morning to everyone. My name is Dr. Evan Thomas. I am the lone radiation oncologist in the group, and although I have the word oncologist in my title, my specialty focus is really pivoted towards using radiotherapy for non-oncologic indications. And like Dr. Lozano and Dr. Dalm, treating movement disorders, Parkinson's disease among them, has become a great passion of mine. So I'm really excited to share a little bit of information about stereotactic radiosurgery with all of you, which interestingly is probably the least known of the three procedural indications we're talking about in the Parkinson's community, but also the oldest of the three. And so I'll cover a little bit of the history of that and how we got where we are. My disclosures. So we've gotten to hear excellent talks on deep brain stimulation and focused ultrasound. And I think one of the points that the three of us would like to leave you with is that all of these three treatments are aimed with the same intent. We're trying to target the same circuit within the brain, and we're trying to engender the same results: reduction in the symptoms, the tremor, other Parkinsonian symptoms, bradykinesia, dyskinesia, by modulating the activity in these dysfunctional circuits. So the main difference is in how we're doing this circuit modulation, how we're getting there, and then what's really involved for each patient. So we got descriptions of DBS and focused ultrasound, but what is radiosurgery? So in radiosurgery, we're using high energy X-rays, weak amounts coming from all different angles, converging in a central focal point, much like focused ultrasound has the convergence of sonication beams. One of the main largest differences is that radiosurgery works a little bit differently than focused ultrasound, and the modulation sets in a little more gradually over weeks to small amounts of months versus immediately. So it has the virtue of being a little bit gentler procedure, but at the expense of taking a little bit longer to take into effect. So again, the word surgery is in the name, radiosurgery, but it's a little bit misleading. Although this is a procedure, technically it is incisionless. We're not physically going inside of the brain. I think it's kind of a misnomer to say it's completely non-invasive, because we are going into the brain and we are intentionally lesioning, creating a tiny dollop of scar tissue to modulate a circuit. So again, we have beams converging all at one point to generate this small lesion. You saw some pictures of the historical legacy of Gamma Knife in Dr. Lozano's talk very briefly, and it showed patients in a frame. So much like DBS has evolved over many years, radiosurgery has evolved as well, and we're now able to position and localize people accurately and safely without putting them in an invasive frame and just a mask. And I'll show you pictures of that shortly. Another great advantage of this procedure, it's as minimally invasive as it is. It's outpatient. There's no anesthesia involved. The procedure is very quick, and patients exit the clinic and go home to their normal lives within about 30 minutes after the procedure is done. So again, as I mentioned, we've come a long way in the history of radiosurgery. The technique to do this was actually invented in the 1950s, and really interestingly, radiosurgery was specifically invented to treat pain and movement disorders 70 years ago, because the inventor, a Swedish neurosurgeon by the name of Dr. Lars Leksell, wanted a way to be able to do something within the brain without cutting. Fortuitously, right around the time the Gamma Knife was invented, L-DOPA became available. And so procedural interventions actually became much less in demand for a number of years. after L-DOPA came on the scene for Parkinson's disease. But then in the 1990s, we saw a resurgence in the interest of using lesional therapy, both with gamma knife, RF therapy, and then that was about the time deep brain stimulation came on the scene as well. And so the modernization of these technologies has allowed us to do things we couldn't do, see things that we couldn't see back in the 1950s when this was invented. So you can see then we used to have to use an invasive frame to immobilize the patients. The treatments on these machines were much slower than they are now. The quickest they could be done is in about 45 minutes to an hour. And then because of how the radiotherapy was made at that time, as the machine got older, the treatments got slower. Nowadays, again, no frame required. Our treatments are done in less than 30 minutes. It's painless, it's incisionless, and there's no recovery period and no side effects. No acute side effects, excuse me. So what it can and what it can't do. So we think about these procedures as really mainly intended to reduce tremor. Although, as you heard, advancements in targeting and selection of different targeting locations within the brain can assist with other types of symptoms as well. But really, the goal of this is to help patients get their quality of life and their autonomy back, help them write, eat, hold a cup steady, take care of themselves, and really to restore people's independence, reduce their social anxiety as well. For radiosurgery in particular, what it won't fix, at least right now, is the non-tremor symptoms of Parkinson's disease, the bradykinesia and the dyskinesia. Those are best addressed with DBS implantation, which can attack multiple symptoms at once. And as you heard, differential targeting now in the focused ultrasound world to be able to treat additional symptoms. So what we're also doing, I mean, we're treating a tremor. This isn't a cure for the whole disease of Parkinsonism. It doesn't stop cognitive deterioration. It doesn't fix the underlying problem, which is the death of the dopaminergic neurons. So if tremor is the driving symptom, radiosurgery is maybe a good fit for you. But if it's not the dominant thing driving your quality of life degradation, it may not. Again, in contrast to the other two methods, radiosurgery works gradually, not overnight. Although we do get some very quick responders, on average, the tremor settles over weeks to months as the treated spot begins to take effect and this small dollop of scar tissue, this lesion evolves over time. So because of that, we do request our patients stay and follow up and maintain serial MRIs with us so that we can follow along as the tremor resolves and as that lesion on the MRI evolves as well. So who are the best patients for radiosurgery? So one of the things that is a barrier to many patients getting deep brain stimulation, or in some cases focused ultrasound, are medical comorbidities that increase the risk profile of those procedures. So some people are on blood thinners and they can't come off of them, and so that may make it difficult to safely do a procedure in which a craniotomy is required and physical hardware is implanted, or even frame pins are placed within the brain. So in people who can't get awake DBS, or excuse me, can't do awake DBS and are contraindicated in anesthesia, this may be an attractive option for them. Many of my patients come in and they've had consultations with phenomenal neurosurgeons, and they tell me, "Doc, I just don't want a device in me," and so that may be a reason as well for these patients. One other group of patients I frequently see are people who attempted to do focused ultrasound, but because of a certain parameter called the skull density ratio, sometimes the sound waves don't traverse the skull to get to the intended place as efficiently as we would all like, and so it can make the procedure very uncomfortable for those patients, and in some patients difficult to get the sonication lesion to the high enough temperature to make a lesion. So for those patients, radiosurgery may be an excellent option as well. Next slide. So what I tell all my patients in here is, my goal is to help you control your tremor, help you control your symptoms, not just to do another procedure. And so I refer a lot of people back out for deep brain stimulation and occasionally for focused ultrasound. So if they have a lot more going on than tremor, then I tell them I can help your tremor, but really you should be considering DBS if we want a meaningful shot at addressing some of these other issues. If some people really want results now. They want to leave the procedure that day, and with tremor relief. And I tell those patients, then radiosurgery is probably not for you. It does require some patience for the results to come, and they do come at the same rate as the other treatments. It just takes time. Um, with regard to bilaterality, you saw Dr. Lozano show that bilateral treatments are being done with focused ultrasound, and of course, they've been done with deep brain stimulation for many years. The data is less mature for doing this in stereotactic radiosurgery, and probably less robust as well. So this is something we are doing on an observational protocol for the appropriately selected patients. Like Dr. Lozano, I ask my patients to wait 6 to 9 months to allow us to see how the lesion is developing on the contralateral side of the brain and ensure that these people aren't going to be someone who's a higher likelihood to have adverse effects from the treatment. But we are doing both sides now, and we have been seeing people get excellent bilateral tremor reduction with this procedure. So what to expect, a little bit of a walkthrough if you think radiosurgery might be right for you or someone who's thinking about having their Parkinsonian tremor addressed. The workflow is a little bit different, and it's very front heavy. A lot of work goes into the planning for the case, and as I mentioned before, the procedure is very quick. So we do like the other procedures, a special treatment planning MRI, which has sequences that allow us to visualize the tracts within the brain that we're interested in modulating. And then once we have this MRI, we'll bring patients back and we make this thermoplastic mask, which is made out of a Kevlar reinforced thermoelastic polymer, which keeps it very stiff and able to keep patients very still during the procedure. We take a CAT scan of people in the mask, and then in the background, all those scans are fused. And myself and any colleagues, we go to work designing a very patient-specific plan to ensure that your particular anatomy is addressed in the procedures. So on treatment day, a patient is positioned on the table, a mask is applied, and we take a scan to align the patient to within a 0.5 millimeter accuracy and precision. Treatment's initiated, and this machine that looks something like it's out of Star Trek rotates around from all different angles. This table moves around. It's almost like a really unexciting roller coaster. That moves at an almost imperceptibly slow rate of speed. But the total delivery happens in 20 to 21 minutes, and then people are free to go about their day and head home. So what happens next? So a tiny focus of scar tissue begins to develop in the tremor circuit, and this causes remodulation and hopefully improvement in the tremor. I typically, on average, see people getting results 4 to 8 weeks later, and then we'll do an MRI follow-up every 3 to 6 months. Like any other procedure in medicine, there is a risk of adverse effects. And in about 1 in 20 patients, I see that their scar tissue starts growing too fast, and I may need to prescribe a medicine to modulate that. And sometimes there's an herbal supplement we're using now, which has a similar effect. What side effects do we see in radiosurgery? I'd say about 10% of patients can expect sometimes a moderate headache on the day of procedure that typically goes away with some Tylenol in a couple hours. In about 5% of patients, we do see changes in their sensation, dysesthesias or paresthesias in the finger and the lip. And in about 3% of patients, there can be a little bit of focal weakness in the hand that we're targeting, and sometimes a little bit of slurring of words. If we catch it in time and we modulate it with medicines, that's almost always reversible. There are significant side effects in about 0.3 to 0.4% of patients where we lose control of the scar tissue reaction, and those patients may require an IV medication and sometimes hyperbaric oxygen therapy. So it's very rare, but there can be serious complications. You can see here, this is kind of what we expect a lesion to look like as it evolves over 6 to 18 months. And typically the tremor relief does kind of correlate with the presence of this T1 enhancing lesion. So to kind of wrap it up, if I'm thinking about a loved one or a family member who's considering this procedure, here's what I'd want them to know. There's definitely more than one good way to treat Parkinson's tremor or other symptoms now. The best one depends on you, your body, your life, what your goals are, what your risk profile is, what your support network is like. For the right candidate, stereotactic radiosurgery is a great option. There is research underway in the radiotherapy field to explore new targets to treat additional symptoms, dystonia, and bradykinesia, but also other approaches to radiotherapy that we're exploring to modulate the cognitive decline in Alzheimer's, or excuse me, in Parkinson's disease. I want to thank you all for your attention and for listening to my talk and my extremely talented colleagues. And I want to invite the other speakers back on to give everyone a chance to do some Q&A and have any of their questions answered.
Thank you so much, everyone. That was fantastic. We heard from our three experts about our three different procedures, and now we're going to start our Q&A. Now, clearly, this is very complicated. There are three different procedures that we talked about, different targets within those different procedures. So a lot of our questions are coming in, and we have a whole bunch that are already been inputted in the chat. So thank you so much. Please keep putting in your questions, and we're going to try to answer as many as we can. Apologies ahead of time if we do not answer your specific questions. So we're going to start with a question from Jeff. So again, just to set the stage, we have our deep brain stimulation, our focused ultrasound, our stereotactic radiosurgery. And Dr. Lozano mentioned this new target, that was really just approved for focused ultrasound, but PTT. And our question from Jeff is, so we understand that the PTT is a new target and it actually targets other Parkinsonian symptoms besides tremor. So the slowness and the stiffness of Parkinson's in addition. And so the question is, what about the tremor? If you have the PTT as your target, will that also help your tremor? So Dr. Lozano, could you answer that for us?
Yes, so the studies are just being published now and being done, but it appears that the PTT target is also quite effective for tremor. So you have the PTT lesion on one side, and you can expect about a 70% reduction in the tremor on the other side. So the advantage of the PTT is that it not only treats tremor, but also some of the other symptoms of Parkinson's disease, including the stiffness, the slowness, and the dyskinesias associated with taking drugs.
Fantastic. Thank you so much for that.
Dr. Lozano, may I ask a follow-up question on that I think some of the listeners may be interested in? When you do bilateral PTT, do you notice more improvement in midline components of the Parkinson's disease than we have historically in bilateral treatments within the thalamus? Any thoughts on that?
So the number of people that have had bilateral PTTs is very small in the world. So there's just not enough data to answer your question. And most of the people that have had PTT have only had it on one side. So I think that eventually we will see bilateral PTT come out, but it's relatively a new target and a new technique. And the data is accumulating, but the prediction is that it will affect both sides and it should improve gait as well. But we need the data to back up that prediction.
Great. I'm going to jump just from what you said to a question that Catherine asked, which I think will resonate with a lot of our audience. So she's heard presentations in the past comparing DBS and focused ultrasound for Parkinson's disease, and the presenter at that conference really seemed to favor DBS over focused ultrasound. Obviously, today we're hearing a little bit more of a balanced approach. Why do you think that is? What's the future? And how do you respond to Catherine about sort of that discrepancy she's noticed?
Well, maybe maybe Dr. Dalm wants to chime in, but I can tell you that some centers don't have all these techniques available, so they will by default prefer one over the other. But I think that if you have all of these techniques available, then you can really offer the full menu to the patients. My personal feeling is that for many things, these techniques are quite similar in terms of their efficacy and their profile of side effects. Certainly when it comes to tremor, I would say that they are quite similar. So then it boils down to, is there a patient preference as well? But let's hear what Dr. Dalm has to say about this issue.
Yeah. Well, thanks, and I apologize for I got kicked off and it wasn't letting me log back in, so I had to like restart my computer. Eventually got back on, but thanks, Dr. Lozano, for finishing off my talk too. Yeah, I think when it comes to the treatments, when focused ultrasound came out, we kind of got back into the more of an ablation therapy realm for treating tremor specifically, and it's very good. And I agree 100% with Dr. Lozano is the side effects are very predictable. They're very similar between deep brain stimulation therapy and focused ultrasound therapy. When it comes to deep brain stimulation therapy for Parkinson disease, we know our two primary targets, GPI and STN. We know STN, they're both good for treating the movement symptoms of Parkinson's, the bradykinesia, the slowness, the stiffness. STN a little bit better with the tremor component as well, about 60-70% tremor reductions. We didn't until PTT really, like Dr. Lozano said, that the data's really just kind of being published, but we didn't really have great outside of thalamic targeting, which just targets tremor. We didn't really have good tremor targets that could treat the movement components of Parkinsonism plus the tremor component as well. I think it'll be interesting to see what happens once the PTT therapy becomes more widespread. Once the data comes out and the papers are published, and we're able to kind of see the long-term effects and the bilateral effects as well. Because that's one of the proponents that's being pushed with the PTT is that you can do bilateral treatments potentially quicker than you can do with ortholamic treatments. And so that it'll be interesting to see how that plays out. And Dr. Lozano is 100% correct. Dr. Thomas talked about this as well. Some patients don't want something implanted. Some patients are afraid of being awake during awake surgery with things in their head. It's one of the reasons why a sleep DBS is kind of nice if you have the ability to offer that and you feel comfortable as a surgeon offering that. But I think now that we're getting better abilities to visualize in the OR MRI guided visualization of where these lesions are being created, same thing with stereotactic radiosurgery, our ability to treat these and feel much more comfortable treating some targets that we used to do just by putting probes in and burning it and kind of for lack of a better way, kind of maybe hoping that we were in the right spot. Now we can see it. We know what's happening. I think we'll start to see this play out a little bit as time goes on and the data comes out. But I think we'll probably see a bit of a trend like what Dr. Lozano pointed to with tremors that we may see at some point. Maybe PTT or ablations are becoming maybe more common than deep brain stimulation therapy potentially.
Fantastic. So really, to answer Catherine's question, it's an evolving field. And so a presentation you may have heard by one physician last month, the new data is coming out, which helps us reevaluate things. And so it's really an active field, which is exciting for people with Parkinson's, that there's a lot more in the future that may be available and new information to assess. We have a question that I'm sure many people are thinking, which is, if you have had one of these procedures, does that prevent you from having another one? So, for example, if you've had focused ultrasound or stereotactic radiosurgery and now you want DBS, is that a possibility? Dr. Dalm, would you take that one?
Yeah, so typically what we tell patients and consult patients on is you can have focused ultrasound. You can have other procedures after that. Dr. Thomas kind of highlighted that maybe we've tried focused ultrasound, got a result or weren't able to complete it for various reasons. And so then we may refer them for stereotactic radiosurgery. You can have focus ultrasound and then potentially have DBS afterwards. Having DBS and then having focus ultrasound afterwards is a contraindication at this point. The ultrasound waves getting through the MRI capabilities and the interference with the magnets and all that just doesn't make it a viable option. Conversely, focus or stereotactic radiosurgery after DBS therapy may be a possibility. Dr. Thomas, you want to comment on that?
Yeah, so that's thank you, Dr. Dalm. That's a great question, and the situation doesn't arise very commonly, but sometimes people do have to have a reason or another, some infection or hardware failure, and then the question arises is what's left for me, or if sometimes the hardware fails and it can't be explanted, can I still get something done? And the answer is, those aren't a barrier to an absolute barrier to performing stereotactic radiosurgery. Who do these procedures, we're very judicious about it and make sure that there's buy-in and compliance, or buy-in and agreement with the patient's entire movement disorder team, whether that's appropriate. But it is an option if the lead's been explanted, or in some situations where the lead has to remain. Great question, though.
Okay, got it. So that's RC's question. So thank you for that. So just we lost your audio for a minute there. So just to summarize what you said, Dr. Thomas, there are situations in which either the DBS has needed to be removed or stayed in place but is not active, and there is some discussion around whether you can have stereotactic radiotherapy in that situation. Would that be a good summary of what you just said?
Yes, we offer it with cautiousness.
Yes, exactly.
I'll just point out, there is one report of focus ultrasound in a patient with a DBS electrode in place as well. So it seems like there's no absolutes here. It may be possible to do DBS followed by focus ultrasound. I think doing focus ultrasound first and then DBS is simpler, but there are no absolutes. I think most of these procedures can be done one after the other.
Fantastic.
And I will just add one comment. There are very rare patients who do not develop a lesion after stereotactic radiosurgery. For some reason, their brain tissue just may be much more robust, or they may have some genetic. And patients, I have referred a few out to focused ultrasound and have been able to get good results in the event where they didn't respond to radiosurgery.
Excellent. Okay, that's really, really good information. A related question from Marlene is what about a cardiac pacemaker? Is that a contraindication to any of these procedures? Dr. Dom, you want to start?
Typically nowadays, no. In most situations, even with MRI imaging, as long as you're not necessarily pacer dependent and you have to have the pacer to actually function for the heart rate, they usually can be placed in a safe MRI mode, and we can do these therapies.
Fantastic. That's also good information. Marilyn asks a great question, which is somebody with claustrophobia. What would be the best of these three for somebody with claustrophobia? Dr. Lozano, would you like to take that one?
Well, we've actually started doing focus ultrasound under general anesthesia as well. So in someone who cannot tolerate the procedure because they can't lie down, we had a patient, for example, who had difficulty breathing just lying down on the MR table. So we converted it to general anesthesia. So it is possible to do focus ultrasound, radiosurgery, and DBS under general anesthesia. So it's something to keep in mind if someone really cannot tolerate being awake for the procedure.
Fantastic. Anyone else want to add to the claustrophobia question? If not, we will.
Like Dr. Lozano said, the sleep procedures are becoming more common. Especially with focused ultrasound, I think people are becoming more comfortable with that as well. From that standpoint, even when we treat patients that have claustrophobia who are awake during something like a focused ultrasound procedure, when we do those, they tend to do quite well, even though they're in the small bore of the MRI scanner. There's things we can do to kind of coach them through it, and there's some medications we can give to help as well. So usually it's not a contraindication that we've not offered DBS or focused ultrasound or stereotactic radiosurgery The nice thing with stereotactic radiosurgery as well is it's much more open, right? The table they sit on and is you're basically just laying on a table itself, and the device kind of spins around you.
Very good. So if claustrophobia is really kind of a main driver, that would be something to consider in terms of stereotactic radiotherapy. But the other two are certainly very amenable to people who may have that issue as well. We have a great question from Kim, and I know this comes up a lot, which is, at what point in the disease trajectory are you considering one of these things? Do you really have to wait until you're advanced? Is it possible to do any of these procedures earlier on in the disease course? So this, I know maybe all of you want to address. Who would like to address that first?
I'll jump in if I may on this one. So I think this really takes us back to this is a very personal decision to each family, each patient and their situation, and how their disease is affecting their quality of life. Some people want to avoid a procedure as long as possible. Some people want to try and minimize the amount of medication they're taking. Some people, even a slight amount of tremor can affect their ability to carry out their day-to-day work, their jobs. So I think we've all treated young as early as in their 20s for these disorders when it was preventing them from doing their job. Some people wait much and until their disease is really not responding to it. So it's a very at least from my perspective, it's a very personalized decision, but there's options on both ends of the spectrum.
Excellent. Anyone else want to jump in on that question, early versus late?
Yeah, I think part of it's the symptom you're trying to treat. So tremor sometimes could be very debilitating and affect your ability to take care of yourself, to eat, drink, put your clothes on and just do things to take care of yourself. So you could get to a point earlier on where maybe that's becoming more burdensome than the core symptoms of Parkinson's. When it comes to just being a candidate, so if we look at like, if someone has Parkinson's disease, they've had it for 4 years. They're having motor fluctuations, they're high medication burden, or they're having side effects from the therapy. If they meet all the criteria, your UPDRS scores are high enough, your on-off testing, where you have you come in on off the medications, test you come on off on the medications and kind of recheck. If you meet all the criteria for surgical intervention, I always tell patients it's kind of like what Dr. Thomas said. It's whenever you feel like you've gotten to that point where the therapy options, the risks, the potential complications, and you're willing to accept all that as a possibility, then don't wait at that point, because it's not going to get better. So just push forward with it.
Yeah, so I agree with Dr. Thomas and Dr. Dalm. I think that there's a tremendous opportunity cost if you have these illnesses. You have Parkinson's, you may not go after that promotion, you may not go after that job because of your Parkinson's, you feel held back. So if you can improve their performance or quality of life, I think it really opens up more possibilities. So we are pushing patients earlier and earlier before they lose their job, before they become, disabled. We think that they should be treated to maintain a high level of function, to keep them, as normal as possible for the longest period of time. So we're moving earlier and earlier in the disease course.
Thank you so much. Very, very good information. So many questions coming in, and we're really coming close to the end of our program. So let's try to get a couple more in, and then we're going to have to wrap up. So Gary asks an important question, and we had another question from, I think, Vera earlier. Do these procedures help things other than what you're talking about? So the two that we hear a lot about are freezing of gait and speech. Do any of these treatments affect those and the potential of making them better? Dr. Dom, you wanna start?
Some of it depends. We do know with DBS therapy, sometimes GPI can worsen freezing of gait. One of the things I kind of classically tell patients is if symptoms get better with the levodopa, it's likely to get better with the deep brain stimulation therapy as well. Yeah, there's possibility for other things to improve beyond that, but I try not to overpromise beyond that. So if they're taking medication, they have a symptom, well, does it get better with the levodopa? And they say no. I'm like, well, maybe DBS therapy is going to help with that, but there's probably a good chance that it might not. And so I like to kind of get a sense for how the medications are helping to kind of guide that question when I get that in the clinic when patients come with it.
Great. Dr. Lozano, any thoughts on those sort of additional symptoms that people are concerned about?
Yeah, so there are some things that these therapies are very good at, tremor, rigidity, slowness of movement. Other things that's less good at, and speech is one of the things that we are not very good at. In fact, speech may get worse with any of these surgical therapies. So I think we have to be very careful. We've had patients that are opera singers, and they are very sensitive to their speech. And in them, we offer DBS because it is adjustable. You can always turn it off. So speech is one of the things that is most difficult to treat, and in general is not responsive to these interventions. The gait is more variable because, as Dr. Dalm said, we use the levodopa response to predict what the DBS response will be or what the focused ultrasound response will be. If their gait improves with levodopa, then it will likely also improve with these other interventions.
Thank you very much. So we actually have time for one last question. And so it's going to be Dee's question, which is, so there's this brand new approval from the FDA for focused ultrasound for a more general Parkinson's symptom treatment. Where do you go to get that treatment? Where is it available and how do you find out? So Dr. Lozano.
Well, it has been approved by the FDA just recently in the last year, and the paper that the approval was based on was published a month ago in Lancet Neurology, so it's brand new. There are several centers in the world that are doing this procedure. So I think find out where it's being done in your vicinity and get referred to that center to see if you are a good candidate and eligible for that particular procedure.
Great. So back to our discussion before that this is an evolving field and new things are happening. And so definitely talk with your neurologist and see if the new thing is something that you can take advantage of. So on that note, we are going to wrap up our Q&A. I really apologize to people whose questions were not answered. We will try to get you answers offline. We have your questions stored, so we will try to get back to you with answers. So stay tuned for that. I really, really want to thank our three speakers for your presentation and for joining our Q&A and for really sharing your expertise. We very much appreciate it. And thank everyone for joining, for participating, for submitting your questions. And the recording of this will be available on our YouTube channel momentarily, so you'll be able to rewatch it if you would like, and you can share it with others. So I want to also alert you that on Wednesday, August 12th, we're going to have our next Dr. Gilbert host. That's going to be at 1 p.m. Eastern Standard Time. And at that time, we're going to be discussing the topic of lesser known symptoms of Parkinson's disease. That should be another very interesting conversation. So be sure to register and you'll join us for that as well. Please join us on our website, apdaparkinson.org. We have lots of information and resources, and you can continue getting a lot of great information from us. So stick around for a few final messages. I want to thank you once again for joining us, and we hope to see you soon on another APDA program. Have a great afternoon, everyone.
Okay.
Hi, I'm Leslie Chambers, President and CEO of the American Parkinson Disease Association. Thank you so much for joining us today on our program. Every day, APDA is committed to providing helpful programs just like this one, as well as a wide variety of support groups, exercise classes, and educational programs to support the Parkinson's disease community. Whether online or in person, APDA is here for you every step of the way. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. We keep you posted on our social media channels as well, so make sure you follow us there. You can also connect to local resources and events through our nationwide network of chapters and information and referral centers. Remember, we're just a click or a phone call away. If you've enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Every gift, large or small, helps APDA support people living with PD through thoughtful programming, reliable resources, groundbreaking research, and more. Please visit apdaparkinson.org/donate today to support our critical work for those with Parkinson's. We are so grateful for your generosity. Thank you.